there are many medications that can be used to treat pain. And sometimes it seems like it's a kind of a spin of the wheel as to which one we choose. And hopefully after today, it'll be a little bit more specified rather than a random spin of the wheel. So we'll start with opioids. Opioids are often considered kind of the gold standard analgesic, but they do have many problems, as we're going to talk about. And in fact, I think it's a reasonable goal for most people who are using medications to treat pain to try to minimize the use of opioids. They come from the opium poppy, and it is derived from the sap in the bud or bulb of the opium poppy. Opioids have many effects on the body. We usually are very interested in the analgesic effects. We might be interested in the decreased anxiety that is also associated with opioids. Sometimes the sedation might be beneficial. Sometimes it's undesirable. Cough suppression, same thing. Sometimes good, sometimes not. Constipation, if they're having diarrhea, then it might be desired, but otherwise it's not desired. And interestingly, it's a side effect that does not disappear over time. There's no tolerance to the constipating effects of opioids. And the euphoric effects, again, there may be times when that's desirable, but generally it's not. And then we have many side effects here that are almost always issues that we don't want. Something to keep in mind is that humans are genetically, have a genetic variation in them. And so therefore we may see some people that are unable to convert codeine into essentially morphine. So that codeine by itself in the body is not an analgesic. It only becomes an analgesic when the liver does a step called O-demethylation and transforms codeine into morphine. But approximately 9% of a white population is deficient enough in this enzyme that they will not get analgesia from codeine. And in an Asian population, this is rarely a problem. It's unusual to find enzyme deficiency, if you will, in an Asian population. In an African population, it varies greatly depending on which areas in Africa someone's ancestry comes from. So there are areas where this is not an issue at all, and other areas where up to a third of the population may have reduced CYP2D6 cytochrome P450 enzyme, and therefore they will not get any analgesia with codeine. And by the way, I kind of went through that exercise as an example of how genetics affects our response to medications. There are other examples, but that is really the classic and one of the first ones that we knew about in pain medicine, already dating back, maybe 20 years already now that we've known that. There are a couple of opioids that are referred to as atypical opioids, tramadol and tapentadol. These may be slightly more gentle, if you will, than traditional opioids. We think maybe slightly lower risk of addiction, but clearly there is still risk. Tramadol is a relatively weak mu receptor agonist, but in addition to that function, it inhibits the reuptake of serotonin and norepinephrine. excuse me, and those are pain inhibitory neurotransmitters in the spinal cord. They do lower, both of these drugs lower seizure threshold, and therefore you have to be careful about combining them with other drugs that lower seizure threshold, like many of the antidepressants. Tramadol, because it inhibits both serotonin and norepinephrine, does create a risk of serotonin syndrome when given with other drugs that also increase serotonin. That risk is negligible with tapentadol, because tapentadol really inhibits the reuptake of norepi and has very little impact on serotonin. Seizure risk, again, is present in both. They are scheduled a little different. Tapentadol is a Schedule II drug, and tramadol is a Schedule III drug. This table is basically just for your reference. Hopefully, everybody has access to such tables. They'll help you figure out if you're giving one opioid or a patient is on one opioid and you want to switch them to another, what a equivalent dose is, or if there's a change going to be made from IV to oral or oral to IV. Typically, the strategy when making a change like this is to initially calculate what the dose equivalence is to the new drug that you want to give, but then underdose that anywhere from maybe 25 to 30%, because these numbers are kind of based on the median of the bell-shaped curve, and your patient may not live there. So you want to start a little bit lower, and then if in fact it is underdosing them, then you can always increase the dose. The Center for Disease Control has issued some guidelines on opioid use, and basically they have said for chronic pain, one should try to use non-opioids wherever possible, noting that typically non-opioids give equivalent relief, are better tolerated, and allow better function, day-to-day functioning. For acute pain, they suggest limiting opioids to a brief period, approximately 3 to 7 days. So this might be after a surgery or trauma. They also provide a warning that opioids and benzodiazepines should not be used together whenever possible. That should be avoided because the combination dramatically increases the risk of overdose and death.